And now we go to a very special keynote lecture for this meeting. Please welcome Professor Quan Lee from Mayo Clinic, Arizona, US.
I want to start by saying congratulations, Hui, on this fantastic meeting. It's phenomenal to watch the growth. Vietnam was the first country back in Asia that I came home to in 2013 after I became a junior attending from the United States. And since then, through Vietnam, I've connected to all the friends from all around the region. It just goes to as a testimony to how, Vietnam has become a center and a collaborator and truly a friend. And I've truly grown in my career, and it's really been a privilege and honor to have had the opportunity to come home here to Vietnam for every year for the last 13 years. And so this is very special. So Dr. Hui, as always, has assigned me a very difficult topic and a very interesting one. So I'll try to do my best in the next 10 minutes, right, before I get cut off, to speak about artificial intelligence and interventional cardiology. Artificial intelligence clearly is like a very dangerous girlfriend, very exciting, but also very scary because what it might mean for our futures. Let's see. Okay. So when we ask the question, how will AI arrive in interventional cardiology? Ernest Hemingway, many, many years ago, had a very good statement. He said it will come gradually and then it will come suddenly. Even since the first time I gave this talk 2 years ago, there have been significant advances, and this is a very exciting field to watch. So there was a centralized thematic article earlier this year from Yanis Chatzidis et al. In JSky in an inaugural issue centered around artificial intelligence. In this issue, they predicted a future, and they stated that the main function of AI in the future will be the democratization of expertise, the allowance of AI to help us no matter where we are and to bring sophisticated informational analytics globally. Clearly, we will be part of pre-procedural planning, device research and development, and then they talk about virtual clinical trials, and of course, the important central role in education and training. So this is a very broad, ambitious vision of the future. We also understand that currently the main downside of clinical trial-based medicine is the non-personalization of therapy for individual patients. AI brings with it the unique opportunity to personalize treatment, but one of the questions we have to ask is who will we be personalizing it for? For us, or for the patient, or for understanding both and figuring out what the best thing for both patient and physician is. There are many concepts in AI that are important, but I think I'm going to boil it down to these statements. AI can be trained through supervised learning, where the machine learns by analyzing selected data and process information to find the best combination. But there is also a huge field of AI, which is in unsupervised learning, where you give the information in raw form, and then we have no idea what it is doing and how it is learning, and then it emerges as a black box. And then we also have reinforcement learning, which is the typical psychological reward loops. Despite all of this, we clearly have learned from ChatGPT, etc., about the dangers of bias in AI. AI has a tendency to hallucinate, and we become over-reliant. We can sometimes be completely misled by the AI. The consequences are broad. You can have inaccurate risk prediction, misleading diagnosis, and it can further emphasize healthcare disparities and discrimination, as we have seen how AI is equally as racist as we can be. But what has the AI, if we were to boil it down to a simple philosophical viewpoint, it allows us to assist us to speed up and simplify the things that we already do, but it also has a special ability to see or do things that we currently cannot see or do. And eventually, the fear, obviously, is that it will replace us to do things we currently do with or without our supervision, and beyond that, to do things beyond our human capabilities. So what are the pragmatic areas of adoption in interventional cardiology to watch when it comes to patient medical records? And we are starting to use this on a daily basis at the Mayo Clinic. rapid summary of thousands of pages of patient records, risk stratification, the personalized medicine, procedure planning, reducing documentation burden. It can do our clinic notes for us. I think all of those of us who have used Abridge have seen this. And then in diagnostics, study interpretation, I'm very sorry, all of those of you who are in imaging, this is not a good field to be in right now. Risk stratification, procedure planning, computer vision, etc. And then during a procedure, it can serve as a live procedural aid, like a Siri for CAF. So let's have a look at a few case studies in AI assisting us to do the things that we already do. This is a great paper from Taiwan last year from New England Journal of Medicine AI. This is an open-label cluster randomized trial where they looked at AI ECG or the standard of care in 43,000 patients presenting to the ER. And they found that the AI ECG had an 89.5% positive predictive value and a 100% negative predictive value in correctly diagnosing ST elevation. The practical effect was that it reduced door to balloon from 82 to 82 minutes versus 96 minutes, and ECG to balloon to 78 versus 84 minutes. So, when applied even in a real world frontline situation like this is better. And for all of us in interventional cardiology who know all about false STEMI activations, this is probably the future of how we will go. There have been many studies on AI in coronary angiography, in segmentation, in frame selection, in lesion detection, localization, and classification, as well as the functional assessment of coronary flow. This is a famous study from Professor Kim and Professor An here from South Korea, the FLASH study that was published earlier this year, where they looked at AI QCA assisted PCI versus OCT guided PCI. And what they found was that it was essentially non-inferior with regards to final MSA compared to OCT. So this is an interesting application because you can basically do this to every angiogram, especially in the world of even 1A recommendation for intracoronary imaging with only 20% global adoption. Maybe we don't have to do intracoronary imaging. Maybe we can just use QCA. So this is a bold little statement. We all know that trying to analyze an intravascular imaging run, all of us, it takes a lot of time to do well. And so many companies have introduced commercial AI on the commercial platforms. The main would be the Avigo with Boston, the Ultron with Abbott, and then Gentuity, HFOCT with Nipro, and Hyperview with Spectranetics. It's no longer become this is something that is novel. It's become a me too. Everybody seems to have a version of this right now. Here's an example of Avigo and what it can do with regards to, but once again, how accurate is it? If we were to use it in a randomized clinical trial, what would we see? We do not know the answer of this yet, but even then, when you look at the agreement between, in this patient from this paper from Matsumura, from JACC Advances, the correlation, the agreement is quite good, but not amazing. We still have to be vigilant. It is still not perfect. Here is a paper about the Ultron looking at morphology. When compared to experts, human experts versus Ultron, there was improved accuracy. Length was not affected, but when it came to diameter measurements, the AI actually had improved accuracy compared to humans. We all know about the very exciting field in the future, especially when photon-gated CTs come and you get much clearer thing, that coronary CTA for PCI planning will become probably a standard thing that we should all be familiar with. Now let's look quickly at case studies in seeing what AI can do beyond what we can humanly see. This was a paper at Lancet looking at how applying AI to databases to improve risk predictions. We're all familiar with our TIMI score, our GRACE score, etc. But when they use AI to figure out what the score should be, they came up with the PRAISE score. And what they found out was when they use AI, the 1 year AUC in external validation cohort was 0.92, far superior than what we have seen so far with our commonly used GRACE score. This is an example of Mayo ECG AI. So this is a patient that I saw, a 76-year-old woman with bicuspid aortic stenosis, normal EF, no coronary artery disease, aortic valve area of 0.7, and the mean gradient of 68. And if you look at that EKG, you are like, okay, there's nothing I see there that specifically says that the patient has aortic stenosis. This is after I perform a TAVR in her, placing a 29 millimeter Evolut FX Plus. You see that the ECG has normalized slightly with regards to morphology, but this is what our Mayo ECG AI saw. So the little X is the last ECG that we did. It knew that she was a woman. It knew that she was about 75 years of age. And then if you look at the little red cluster before we did the TAVR, it said that there was a 70% chance that this woman had aortic stenosis. The day after we did the TAVR, the probability dropped to 30%. So the ECG saw from those two ECGs that you saw, the AI saw, it predicted that the woman, well, it was a woman, she was the right age, and that she had aortic stenosis. It is really phenomenal. I have no idea how it knows these things. And there are many other diseases that we are applying the AI for, including cirrhosis. It can actually tell whether a patient has cirrhosis. So this is another example of the real-world application of AI. This is the Queen of Hearts model, the PM Cardio STEMI. It's FDA approved. We are using it in the United States. Tim Henry has actually presented some data at TCT. And what you see up here is an EKG of somebody coming in with chest pain. There is no STEMI on the ECG that you can see as a cardiologist. But when they applied the ECG OMI model interpretation, it actually detected and called it out and said, yes, there is actually an acute ST elevation MI happening right now. And true enough, on the angiogram, there was a mid-circumflex occlusion. So you can buy it on the App Store and use it. I tried using it on rounds, and it actually works quite well. um, so we all know about angiography-based intracoronary physiology. Obviously, there are many things, and this is not really the place to go into detail. The most studied is QFR by far. We have learned much from QFR, but the fastest and most complete in all vessel analysis is really CathWorks FFR angio. But not much clinical data, and it remains to see what we do. In the field of TAVI, there's the FEOPS heart guide from Belgium. And what it does is it tries to predict, looking at the calcium morphology, where your pressure points are the highest, and the red little spots are the highest. And based on the relationship between the septum, basically it's used to predict paravalvular leak and pacemaker risk when you implant a virtual valve. And in the study that was presented in CCI, it changed procedural planning in 35 of patients when used for high-risk anatomy and did accurately predict paravalvular risk and pacemaker risk. So let's look at the future. What is the possibility of autonomous PCI replacing us as operators? There is, fortunately for us, the artificial intelligence paradox, which is Moravec's paradox. AI brings incredible intelligence, but is at the same time really, really dumb. It is comparatively easy to make computers exhibit adult-level performance on intelligence tests or playing checkers, but it is almost difficult, impossible, to give them the skills of an infant when it comes to perception and mobility. So for those of us who work with our hands, we are probably safe for at least another half a century, I hope. No job loss. Robotic PC. I think the most exciting part about AI is the possibility of using. I know we have pulled Corindus off the market, but when we ask the question, how are we going to truly get primary PCI out to the world, right? In Indonesia, you have what, 20,000 islands and 270 million people. This might be ultimately actually be the way that we can get primary PCI in a timely manner to a large dispersed population. It's possible. So when we look at the problem of human vigilance, when AI is correct half of the time, we are basically just going to say AI is useless and it won't be used. When AI is correct 70 to 99% of the time, we are simply going to be tasked as safety supervisors. So we're going to stand there and say, okay, yeah, the AI is correct, that's fine, let's go ahead, or it's wrong, let's change our strategy. When AI finally becomes 100% correct all the time, it's going to be enthusiastically adopted, and the humans will gradually be removed. So in this picture, you have the co-pilot, two of them, and now we have the autopilot. And in the future, when AI gets really good, the dog will come with us, but the dog's job is to bite us if we try and touch the buttons. So how do we approach this future philosophically, right? There are 4 rules for co-intelligence from this great book about how to survive the transition. For now, always invite AI to the table because you have to understand its abilities and limitation. You must understand your role as being the human in the loop and try to mitigate the forces that make it hard to get right. Treat AI like a person, but tell it what kind of person it is. You have to customize it. And for all of those of you who want to say AI is not the future, assume that the AI that you are using now is the worst AI you will ever use, because we have seen it over and over again. Within two months, the next version we play with is so much better. Um, so my final thoughts on AI adoption: expect predictable problems in early adoption, such as hallucinations and automation complexity. Be alert for unpredictable problems. There will be political pushback when you start to introduce it. Everyone will talk about you as the co-pilot rather than AI as an autonomous engine, but this is probably short-sighted. With the needs for healthcare transformation and the rising exponential cost of healthcare and the possibility that AI could be so much cheaper, um, when you couple this with rapid improvements, this will happen gradually at first, and before we know it, it will be sudden. Thank you.